Round of applause for Andrew, and also thank you, Andrew, for the slipper recommendation.
Thanks very much. Fantastic to be here, and thanks very much to Quinton and Dylan for another fantastic conference, and particularly for the snow and the weather that they've managed to organise this week. So they reckon a good day skiing is a day where you don't get to see an orthopaedic surgeon. So apologies, because I've just ruined all your days. My kids are in the audience today, and the last time I gave a talk with my kids in the audience was about 10 years ago at Sydney Uni, and just as I was about to walk up, I can't remember if it was my son or my daughter said to me, "Dad, these people must be really desperate to want to listen to you." I had similar comments today. So I'm an orthopaedic surgeon, and this is a little spiel on some foot and ankle trauma. So I'm born and bred in Sydney, and this is a picture of me on the left and my brothers and sisters at Whale Beach, which is one of Sydney's northern beaches where you're not allowed to swim at the moment because there's too many bull sharks. I did my fellowship in Dublin where, apart from learning a little bit of foot and ankle surgery, this came along. We all know that Guinness is good. And you can see here the babe getting Guinness via the breast milk. But what we found is it's not long until the babe can drink it herself. And I'm a foot and ankle surgeon at Royal North Shore Hospital in Sydney, and I also do some work out in Dubbo, out in the central west of New South Wales. Now the other thing about me is being a humble orthopaedic surgeon makes me the black sheep of my family, because my father and brother pictured here are both urologists. And if you look closely, you can see that my nephew from an early age was afflicted with the family disease as well. So this is a bit of a spiel about some foot and ankle fractures, so in the foot and the ankle, looking at some Achilles tendon injuries and also some ligamentous injuries in the foot and ankle. So as we all know, phalangeal fractures are very common. You can see here an example of a fracture of the proximal phalanx of the second toe. Probably fifth toe proximal phalangeal fractures are the commonest of all. Most can be managed non-surgically, so with a buddy splint, as you can see here, in a rigid soled sandal and a short walking boot. You need to contemplate referral to an orthopaedic surgeon if there's a clinical deformity, if the joint's involved, or if the fracture's compound. As you can see here, this is a fracture with a significant clinical deformity that was managed with a closed reduction. Metatarsal fractures likewise are relatively common. You can see here an example of a neck of fifth metatarsal fracture. A base of fifth metatarsal fractures are very common where they are avulsed from the peroneal tendons or the plantar fascia. And this is another common fifth metatarsal fracture through the shaft. Jones fractures are fractures of the proximal phalanx at what we call the watershed area. So there's quite good supply both proximally and distally, but there's pretty ordinary blood supply right where that fracture is. So most metatarsal fractures can be managed non-surgically. Weight bearing is comfortable in a walking boot, but you need to contemplate surgery if the metatarsal fractures are markedly displaced, if there's multiple metatarsal fractures, or that Jones fracture that I just showed you because of the poor blood supply. And most of those, and particularly Jones fractures in athletes, need to be managed with an intramedullary screw. Lisfranc injuries are an injury to the ligament in between the base of the second metatarsal and the medial cuneiform. And you can see here on the x-ray on the left-hand side, you can see that there's increased space between those bones compared to the x-ray of the right foot. And these are injuries often associated with multiple avulsion fractures as well as the ligamentous injury itself. You can see here one where it's more widely displaced, so there's a big gap in between the base of the second metatarsal and the medial cuneiform. And you can also see that there's a step at the second tarsometatarsal joint there, so the joint at the base of the second metatarsal. It's important with Lisfranc injuries in the hospital setting, and once the patient is able to get a weight-bearing x-ray, because you can see here on the left, in the non-weight-bearing view, the relationship between the two bones looks pretty good, but as soon as the patient takes weight through that area, you can see that there's an opening between the bones, and that's a very important investigation to get. Lisfranc injuries tend to be as a result of a forced plantar flexion or a crush injury. They present with midfoot pain and difficulty weight bearing. They often have some plantar bruising, as we'll see shortly, and sometimes loss of the medial long arch height. And the diagnosis is partially based on the midfoot squeeze test, where you palpate the patient's tarsometatarsal joints. This is an example of a widely displaced Lisfranc injury. You can see here the dislocation also in the lateral view. But this is a more subtle Lisfranc injury where you can see the bruising on the plantar aspect of the foot, and that's an indication of a Lisfranc injury. Non-displaced Lisfranc injuries can be treated non-surgically, again in a walking boot. The displaced ones, however, need open reduction and internal fixation, and this can be done with a combination of tight ropes, with screws, with plates and with K-wires. And the reason that we like to put them back in place is to decrease the risk of degenerative change in the midfoot in the years to come. You can see here another example of an open reduction and internal fixation of a Lisfranc injury. So in summary, Lisfranc injuries are caused by forced plantar flexion. Look out for that plantar bruising. Non-displaced injuries do not require operative intervention, but the ones that are out of position require plates and screws. Moving along to calcaneal fractures, you can see here an example of a fracture of the anterior process of the calcaneus. You can see that there demonstrated schematically. This here, if the laser pointer works, you can see a fracture down here through the middle of the calcaneus, and as is the case with most calcaneal fractures, it tends to go up into the subtalar joint. This is a particular type of calcaneal fracture where the Achilles tendon has been avulsed, and you can imagine that bit of bone is sticking out into the skin, so that's something that needs to be fixed relatively urgently in order to stop a big area of necrosis at the back of the ankle. This is an example of a markedly comminuted calcaneal fracture. Fractures like this tend to be in young males because they tend to be more stupid and often pharmacologically induced. You can see here a CT scan of a very comminuted fracture in many pieces. This is the type of thing that your local orthopaedic surgeon likes because we can get out a knife and we can put in some plates and some screws. So this is an example of a calcaneal plate. And you can see not a bad reduction achieved from the mush of bone that was there originally. We now tend to do calcaneal fractures through a slightly different and smaller incision through what we call the sinus tarsi approach, where you can access the subtalar joint quite nicely, reduce the fracture and put in some plates and screws. This is an example of even smaller incisions done with a percutaneous technique using just screws and sometimes an arthroscopy into the subtalar joint. And you can see with the appropriate fracture, a nice reduction can be achieved there. So calcaneal fractures, minimally displaced, extra-articular fractures tend not to be requiring surgery, but any of those that are displaced, and particularly those that involve the subtalar joint, need to be managed with open reduction and internal fixation. Orthopaedic surgeons are simple beings. We can only handle classification that includes 3 different things. So the Weber ankle classification is perfect. Weber A fractures are below the level of the ankle joint. Weber B fractures are those at the level of the ankle joint. And Weber C fractures are those above the level of the ankle joint. Even an orthopaedic surgeon can remember that. So here we see an example of a Weber A Weber B and a Weber C fracture. There's lots of different ankle avulsion fractures. Here's an example, and a very common one, of an avulsion fracture from the tip of the fibula, which tends to involve the lateral ankle ligaments. Doesn't need surgery. In the vast majority of cases can be managed nicely in a walking boot. Similarly, most Weber A fractures tend to be non-displaced and therefore don't require surgery, and again can be managed in a boot. Weber B fractures, if they're minimally displaced, likewise do not require operative intervention, but if they are displaced, such as this example, we like to get out a plate and screw and put it back in place. Most Weber C fractures, because of the nature of the injury to the associated ligaments, often need open reduction and internal fixation. And you can see an example there. The initial x-ray of the ankle, you can't actually see the fracture, but as soon as you look proximally, you can see the fracture, and that's the type of fracture that requires open reduction and internal fixation. And this is another high Weber C or Mays nerve fracture where you can see it's all the way up in the neck of the fibula where the fracture is. Nearly always involves an injury to the ligaments in between the 2 bones, the syndesmosis, managed here with tight rope. Most bimalleolar fractures, so fractures that involve both the lateral and the medial malleolus, are by definition unstable and require open reduction and internal fixation. generally with a fibrillar plate and screws and a couple of medial malleolar screws, as we can see here. So Weber A and avulsion injuries mostly can be treated non-surgically. Weber B fractures require open reduction and internal fixation if there's more than 2 millimetres of displacement, and most Weber C fractures require surgery because of the associated syndesmotic injury. This is a higher energy injury, a tibial plafond. This is a 53-year-old patient who fell from scaffolding at work. He was initially managed with a closed reduction and an external fixateur. And that's a really good way of just resting those miserable soft tissues that have really copped a pounding in the injury. And you can see here on the CT scan, you start to get an idea of the comminution of the fracture, and in particular, the intra-articular damage that has been done. And the 3D recons really nicely give us an idea of where all those fragments are. So most of these fractures require a period of rest, with the foot elevated, with the frame on, just to let the soft tissue settle. And then your friendly orthopaedic surgeon gets on to do what she or he loves to do, make a cut, put in some plates and screws. Happy days. Moving along to Achilles tendon ruptures. The Achilles tendon is the most commonly ruptured tendon in the body. It tends to be a disease of middle age, and it tends to be predominantly males. Tends to be recreation, sporting activity with an eccentric motion and a sudden acceleration or deceleration. And the classic example is dad trying to impress his kids with a 100-metre sprint at the athletic day, or the dad trying to play netball with his daughter. A recipe for disaster. Patients often come in, feel like they've been kicked in the back of the heel, and they turn around and disappointingly there's no one there. The diagnosis for an Achilles tendon rupture in the vast majority of cases is clinical. It's the history that they give. It's the palpable gap in the mid-substance of the tendo Achilles and Simmons and Thompson test, which I'll demonstrate shortly. In the vast majority of cases, investigations such as X-ray, ultrasound and MRI scan demonstrated here aren't really required. This is Simmons test, where you can see where the calf is being palpated and there's no motion of the ankle joint. And shortly you can see that lovely defect in the mid-substance of the tendon. Treatment for Achilles tendon ruptures is now relatively controversial, and both operative and non-operative treatment are both very successful. The advantage of surgery is the re-rupture rate is slightly lower, but it's still not that different in that with surgery the re-rupture rate is about half of 1%, with non-surgical treatment the re-rupture rate is somewhere between 2 and 5%. There's evidence to show that there's a quicker return to manual work and elite sporting activities if you have surgery, but only by a month or so. Of course, there's a much higher risk of infection, and both operative and non-surgical treatment, there's a risk of deep venous thrombosis. The downside of non-surgical treatment is that there's a slightly higher risk of lengthening and therefore long-term weakness, but if non-surgical treatment is done well, that is extremely uncommon. So surgical and non-surgical treatment largely depends on patient preference, on their age, whether or not they're an elite sports person, and their occupation. Surgical management can now be performed through a relatively small incision, as demonstrated here. You find the two ends of the tendon, you put a suture through the proximal and distal end, join the two of them together, and then stitch up the wound. At surgery, I give patients 2 grams of cefazolin, I give them all Clexane, and all patients with an Achilles rupture are on Xarelto for 8 weeks, and then aspirin after that. After surgery, they go into a front slab in Aquinas for 2 weeks, and they're touch weight bearing for 2 weeks on crutches, which is quite hard work if you've ever been on crutches. Non-operative management for the first 2 weeks, the patients go into an air cast boot with 3 hindfoot wedges that puts their foot into Aquinas and approximates the ends of the Achilles tendon. They keep the boot on at all times with the exception of showering. After 10 or 14 days, I'll re-examine them. If there's still a palpable defect, then they need surgery, but in the vast majority of cases they don't, and they go on to continue with non-surgical management. Between 2 and 5 weeks, both surgical and non-surgical patients are in a walking boot with 3 hindfoot wedges. I'll let them start to take weight. They can take the boot off to start some gentle range of motion exercises, but they need to be careful not to dorsiflex too far. Between 5 and 8 weeks, they continue to weight bear as comfortable in their walking boot, and they remove one of the wedges each week. They can start to be more aggressive with their range of motion and strengthening exercises. They can jump into a swimming pool and do some walking in the pools and gentle swimming, and I start them on an exercise bike. From 8 weeks onward, they wean out of the boot as they can. Some patients like to start off walking with a 10-degree heel wedge. I get them off to the physiotherapy. You keep them in the pool, you keep them in the gym. And there's a slow return to full activities. Most patients are able to form a single leg heel rise by about 4 to 6 months. Most patients can start some light jogging after 3 to 6 months, but full recovery from an Achilles tendon injury, managed operative or non-operatively, is something like 9 to 12 months. So it's something to be avoided if you can. So, Achilles tendon injuries tend to be middle-aged males reliving their glory days. Operative or non-operative treatment is very reasonable, and there's really not a lot in it, and I think it's very much dealer's choice. Definitely non-operative treatment if there are any risk factors such as peripheral vascular disease, if there's any issues with their skin, if they're diabetic, and if they're anything over 50. I tend to manage them operatively if they're young, if they're elite athletes, or sometimes if they're manual workers. But either way, full recovery takes 9 to 12 months. Moving on, question?
When do you like to do operative repair? Because there seems to be controversy about whether you want to see it quickly or wait for a few weeks.
Yeah, so there's no hurry with surgery. Any time within the first couple of weeks is absolutely fine. I mean, once they get out to 4 to 6 weeks, it's a little harder to bring the ends together, but there's definitely no urgency in doing them. And sometimes it's a little bit easier, in fact, doing it after a couple of weeks where the tendon has started to heal. So, moving on to lateral ligament injuries. Fortunately, there's only 3 lateral ligaments, so again, good for orthopaedic surgeons. There's the one at the front, the one in the middle, and the one at the back. Lateral ankle injuries are very common, as we can see with this tennis player. They tend to be an inversion, sometimes a plantar flexion injury. Mostly they involve injuries to the anterior talofibular ligament, sometimes the calcaneofibular ligament, and rarely the posterior talofibular ligament. And the important thing to know with lateral ankle injuries is that the vast majority of them heal without needing surgery, even if the ligaments are torn. So surgery is only a consideration with recurrent injury and after the failure of all non-operative measures. So really the key to lateral ligament injuries is a program of physiotherapy with range of motion, perineal strengthening and proprioceptive retraining exercises, and often using some form of strapping or bracing as they return to sport. The patients that do need surgery are those that have recurrent lateral ankle instability, so the diagnosis is largely in the history. The physical examination, there's often some lateral tenderness over the ligaments and the anterior draw test, and this is a time where it is useful to get an MRI scan, not only to look at the patient's ligaments, but whether or not there's any other pathology, including damage to the osteochondral area. This is the example of the anterior draw test with a chronically sprained lateral ligament. You can see how the ankle comes forward as you pull through with the heel there. And you always compare it to the other side. So in patients who have recurrent lateral ankle instability, they are managed surgically. Basically a small incision over the lateral aspect of the ankle, drill a couple of holes into the distal fibula, and then place in a couple of suture anchors. Those suture anchors each have 4 sutures attached to them, and you use the 8 stitches to repair the lateral ligaments. They're managed for a couple of weeks in a back slab. They go into a walking boot for 4 weeks, weight bearing is tolerated. They start range of motion exercises relatively early. They start weight bearing at 6 weeks, and most patients are able to return to most activities within 3 months or so. Moving along to syndesmotic ankle injuries. Again, thank you very much, but there's only 3. The anterior inferior tibiofibular ligament, the interosseous membrane, and the posterior inferior tibiofibular ligament. And the strongest is at the back and the weakest is at the front. Syndesmotic injuries tend to be an eversion, dorsiflexion, and particularly external rotation injury, and often there's a fixed foot and the body twists around it. They're often missed, particularly initially. On examination, they tend to be tender over the distal syndesmosis, and if you squeeze the tibia into the fibula, often the patient doesn't like it as it releases. They often have some pain with passive external rotation and dorsiflexion as well. Plain radiographs are useful, and you can see here On the right-hand side of the screen, you can see the opening between the tibia and the fibula, whereas on the normal x-ray, you can see that in all views there should be some overlap between those two bones. And the other thing to note is the widening of the medial gutter. So you can see on the right-hand side, there's quite a distance between the medial malleolus and the medial talus, whereas on the left-hand side, you can see that there's much better congruence and a much smaller distance. So they're the things that you need to be suspicious of. And as we talked about earlier, often there's an associated proximal fibular fracture as well. MRI scan, you can see here the space between the tibia and the fibula, and normally you should be able to see the anterior and the posterior inferior tibiofibular ligaments, which aren't identified on that MRI scan, indicating that all three of those ligaments have been torn, and this is the type of patient that requires surgery. So syndesmotic injuries, if they're non-displaced, then they don't require operative intervention and they can be managed in plaster or a walking boot. But patients where the syndesmosis is unstable require an arthroscopic debridement and internal fixation. So at the time of surgery, after doing the arthroscopy and cleaning out the ankle, we put a clamp like this on to hold the tibia and fibula in place. And you can see there, get an x-ray and eye picture in theatre to make sure that the ankle is nicely reduced, and then get out our friendly drill and pop in a couple of screws. So hopefully with this talk you've learned a little bit about foot fractures, ankle fractures, a little bit about Achilles tendon ruptures, and a little bit about lateral and syndesmotic ankle ligament injuries. Thank you very much. Any questions?
Run a microphone.
Nigel?
Thank you. I was just wondering, if, going back to the Liz Frank injury, if you suspect it at the outset, do you do the weight-bearing x-ray or the left-right x-rays right from the get-go?
So if the patient is able to take weight, then you can do it at the start. But often with Liz Frank injuries, they're quite sore, so they are unable to take weight they're unable to take weight. So you wait until they can do it, which is often 10 days or 2 weeks. If they can't after 10 days or 2 weeks, then I would be pretty suspicious that there is a Liz Frank injury there, and that's when you think about using the other modalities, such as a CT scan or an MRI scan.
Any other questions? All right. Well, let's thank Andrew once again.